Wine can prevent cancer, or does it cause cancer?
I don't think this video is about scolding those people that love and care and those people that have misstepped with their words.
Have you tried yoga? Yeah, I have.
I think this is really about the NBC community having a good laugh.
Have you swam in Lake Tiki Taka? Tiki Taka?
Hi, and good afternoon, everyone. Welcome to the AACR ABCF Special Education Session. I'm so glad that you guys are able to join us today. Now, for those of you who do not know me, I'm Karen Russell, and I am with the American Association for Cancer Research, AACR. We've teamed up once again with the Alamo Breast Cancer Foundation to bring yet another exciting session dedicated to breast cancer advocates for breast cancer research. So I'm going to ask that you have all questions that you ask them in the chat box, and they'll be answered at the end of the presentation. So today, Dr. Jenny Chang is going to be joining us. She's the Emily Herman Chair in Cancer Research, Director of the Cancer Center at Houston Methodist Hospital in Houston, Texas, and she's going to be discussing cancer stem cells with metaplastic breast cancer. She's a world-renowned clinical investigator, credited as one of the first to describe intrinsic chemoresistance of cancer stem cells. Her work focuses on the mechanisms that regulate cancer stem cells and tumor microenvironment, as well as initiating and planning clinical trials that target these pathways. So ladies and gentlemen, you are in for a treat. So please welcome Dr. Jenny Chang.
Karen, thank you so very much. Today, I'm going to basically maybe speak off the cuff a little bit, tell you what some of my work, but also bring in some of the really exciting things that we heard of this morning. It's really quite an exciting time. We're getting to understand so much more about what actually causes metastatic breast cancer, and are there ways in which we can block it? Does one size fit all? So many new things that we can talk about today. Could use some of the platforms, some old data, but to build it in the context of something that is very, very important. Now, I am going to talk about a rare type of breast cancer, a rare triple negative breast cancer called metaplastic breast cancer. I'm going to use this as an example because this is one of the most lethal types of breast cancer, one of the most lethal types of TNBC, to be very more accurate. It's very, very chemorefractory. It metastasizes frequently to the lungs, and median survival is much, much shorter than even for metastatic triple negative, which we all know is not necessarily the most druggable and the most targetable. Next slide, please. So cancer stem cells and metaplastic breast cancer. Next slide, please. So again, I'm going to concentrate on one subtype, triple negative, because it's one of the least druggable. We know breast cancer is the most common malignancy and the second most common cause of death in women from cancer in the United States. TNBC is basically a type of cancer that lacks estrogen receptor, lacks progesterone receptor, and lacks HER2. And breast cancer as a whole is divided into luminal A's and B's, which are generally the estrogen-driven cancers, HER2 enriched, generally the HER2 cancers, and TNBC. And TNBC is 10 to 20% of all breast cancers. And it has the worst prognosis in comparison to ER positive and HER2 positive breast cancers. Next slide. Now, the complexity is that TNBC is a diagnosis of exclusion. The tumor does not have estrogen, does not have progesterone, and does not have HER2. But it doesn't tell us what it does have. So what we now know is there are different things that make up TNBC. And some TNBCs are basal-like, perhaps the most common. Some have immune reactions and immune cells like the lymphocytic infiltrates that can come in. Others have androgen receptor. And then you have this group called the metaplastic breast cancers, also known as Claudin-Low, also known as spindle-like, sarcomatoid. So this range of subtype called the mesenchymal, metaplastic, Claudin-Low, they fall under this bucket. So next slide. Oh, didn't like this slide, but never mind. So what is important about the metaplastic breast cancers is this. It looks different. So many, many years ago, and we were one of the first groups, and what we did was we took biopsies from women who were enrolled in clinical trials, and we did a biopsy before and after chemotherapy, and we looked at residual tumors. So we know now, and this was the first paper that came out, we know now that if you do not get a pathologic complete response to neoadjuvant therapy, if you have TNBC or if you have HER2 breast cancer, in these two subsets, if you have any cancer left behind, if the treatment that we are giving you in the preoperative setting does not eliminate all cancer, your prognosis is significantly worse. So we basically, now this paper is old, I mean, this is now talking more than 10 years ago, we looked at what were the signatures of those cells that were left behind, the residual tumors. And what we found is the stem cell signature, this Claudin-Low signature, and that these signature corresponded to cancers that were resistant to treatment, had the propensity to regrow, had the propensity to metastasize. This stem cell signature, this metaplastic signature, this Claudin-Low signature was what was responsible for treatment relapse, metastases, and ultimately fatality. So with that in mind, what we did was we basically wanted to figure out what were the drivers. Today, if you were listening to the session, it was very, very exciting. I'm going to talk a little bit about some of the things we're doing, but we have what they have found is that these residual tumors, very much like what we did, and we also found it is there's a proto-oncogene, so oncogene, a driver gene called MYC that drives this, and that these tumors have MYC, they have stemness, they have renewal, they have ability to relapse, metastasize, and now we're learning new pathways. But it's very much similar to the initial work that was done 10 years ago now. Next slide. So, and then we proved in multiple data sets that these signature, if you have this signature, the stem cell signature that is present in the residual tumors, your tumor was resistant to endocrine therapy, resistant to chemotherapy. These was one of the earlier studies. Next slide. And this Claudin-Low, which is the metaplastic signature, corresponded very, very closely to our stem cell signature. Next slide. So what are metaplastic cancers? So there are some cancers, triple negative usually, that have metaplastic features. And this is almost the same as the Claudin-Low, almost the same as the signature we found after residual tumors. So we deliberately concentrated on metaplastic cancers because this is the most stem-like of all breast cancers. Triple negative in origin, completely resistant, almost completely resistant to chemotherapy, and it's very, very rare. So true metaplastic cancers is less than 1% of all breast cancers. You perhaps have less than 10,000 to 50,000 a year at most. It has the worst prognosis compared to all other triple negative breast cancers. So what do we know about this type of cancer? Not very much because of its rarity. But if we know what makes it, what drives metaplastic cancers, then we will understand more of what is present in residual tumors and what is driving metastases and relapse. So other people, Stacy Mulder and others, and work that we had done together with MD Anderson, we basically found that PI3 kinase, which is this one of these pathways first described by Lewis Cantley, this pathway was very, very frequently showed abnormality in this pathway. And then more recently, we showed another pathway called nitric oxide by finding 2 genes in metaplastic breast cancers. In fact, when in collaboration again with our colleagues in MD Anderson, we found that we looked at 40 metaplastic breast cancers, and again, this is very rare breast cancer. We found that most had mutations in this pathway. So we have 2 major pathways. Next slide. So I'm going to describe a little bit more about this metaplastic breast cancer. So what you have on the top, 2 panels on the left, is a normal breast, and then you have triple negative breast cancer. And if you see triple negative breast cancer, they're more or less neatly arranged, like little cobblestones. Then you have the metaplastic spindle, metaplastic squamous, metaplastic chondroid, and osseous. And in these metaplastic cancers, what you see is is in disarray. It's like spindle-like cells. Instead of being cobblestones, they become like needle-like spindles that can pierce through the vasculature and cause cells to basically circulate in the CTCs and cause metastases. And you have different features behind these metaplastic cancers. So they don't look like common garden variety TNBC. They have a different features with it. And if you have these features, if the tumor has these features, prognosis is not as good. Next slide. And so we published very recently a very talented MD PhD student of mine went to a database, and you can see very simply the blue lines is not good enough, but that is basically breast cancer. Once it's metastatic, as you can see, you have median survival and it drops off with time. But the magenta red line is you compare that and you see how much more abruptly and how much worse prognosis is compared to non-metaplastic breast cancers. And here, if you want to do median survival in months, non-metaplastic breast cancer, 160 months, which is a significant period of time, and that is, much, much less than that, about a third if you have metaplastic breast cancer. Next slide. So what do we know about the pathways that drive metaplastic breast cancer? This is what's in the literature at the moment. So I'm going from the top. Wnt, beta-catenin, this is very much a stem signature. We know that they undergo EMT. You hear a lot about this, and this is when the cells change from the cobblestone to the spindle-like cells. There's a process called epithelial, which is a cobblestone, mesenchymal, the spindle-like transition, EMT. And this EMT is responsible for some of the pathways that drive metaplastic cancers. There's some in the literature that says maybe metaplastic breast cancers are more responsive to immune checkpoint inhibitors. There's some EGFR amplification. And then I told you a little bit about this PI3 kinase, which is the most abnormal in metaplastic, followed closely behind by nitric oxide signaling, which we published in several top journals recently. Next slide. So let's talk a little bit about the PI3 kinase. Okay, no, next slide will work. So next slide. So here, the Claudin-Low and the metaplastic cancers, what you can see, and this is again data from MD Anderson, is that most of the cancers, this is all the pathways that are all the PI3 kinase, the 1, 2, 3, 4, 5, 6, all of them, The first 6 on the left shows the number of cancers or metaplastic cancers that basically have an aberrant pathway here. And you'll see that a lot of them do, most of them do. Next slide. So based on this data, now quite old, about four years ago, my colleague Stacy Mulder began perhaps the best study to date on metaplastic breast cancers. And it was serendipity. She happened to have a patient, because she's a very busy clinician, come in, and we all knew, she knew as well as I, that this metaplastic young patient had a poor prognosis because she had metaplastic breast cancer. And she basically, through the kitchen sink, in a off-label way, she basically used whatever she could lay her hands on, and there was some liposomal doxorubicin, some Avastin, and then she also threw in this mTOR inhibitor. mTOR inhibitors is what hits PI3 kinase, the first pathway that I told you about. And very interestingly, what she found was that if you basically use this cocktail and hit PI3 kinase, you had a dramatic response in metaplastic breast cancers. And that was very, very exciting. And she finished publishing this paper, and she basically showed an overall clinical benefit in patients of about 30-40%, which was good. Next slide. So we have gone on further to try and figure out different pathways. And again, I'm just banging home on this PI3 kinase pathway, which is perhaps one of the major drivers in metaplastic breast cancer. Next slide. But it's not good enough, because we know that, unfortunately, breast cancer is very smart. If you do not use combinations, if you only hit one, what happens is another pathway gets upregulated. So from our work, which we did in stem cells, we found that this pathway called nitric oxide was one of the major drivers. Now, this pathway was given the Nobel Prize for vascular disease a number of years ago. And so there were molecules and their drugs out there to target this pathway. We stumbled upon this pathway because of all the sequencing work we were doing in residual tumors. And we found that one of the major drivers in residual tumors was this unusual pathway called nitric oxide. And this nitric oxide was also present in metaplastic breast cancers. In fact, most metaplastic breast cancers also had aberrant nitric oxide signaling. This is an unusual molecule. As a disclaimer, which I don't know if I've done, but I have to disclaim that basically I'm an inventor of a drug of this pathway, and I need to put it in my declarations if I have, and I'm not overselling it, but I have to put it in. I forgot to say. And this pathway is something we found, and we basically repurposed a drug which was used for cardiovascular disease, but we repurposed this for breast cancer. Next slide. And what we found, metaplastic breast cancer, this is published in JNCI, Journal of the National Cancer Institute. And here, I'm going to do the big graph on the right. If you had high nitric oxide signaling, as shown by the red line, you have a significantly worse survival if you have metaplastic breast cancer. So metaplastic breast cancers are already bad actors as they are, but if you also had overexpression of iNOS, you even did worse. So we are even carving out a subset of metaplastics that do really poorly. Next slide. So now we have two major pathways, maybe three if we talk about immune modulation. So we have these pathways that are present. And we can't always test in humans, even if prognosis is not good. We can't, what Stacy did is not usual. She was very brave, and I think she was driven by a need to help. But generally speaking, what we try to do is to try to see whether we can have a rational combination of drugs. And based on that, what we have done, is, if you have heard, is that we can create these patient-derived xenografts. And from here, we take biopsies from patients, we put it into mice, and it grows as the patient's tumor in a mouse. So we can test the patient's tumor in different combinations in the mouse instead of testing the patient. Now, one step further, and we've also done this, we've done two things to adapt to this. Next slide. We have a ton of this, and in breast cancer, we have 75. Most of these breast xenografts are actually triple negative. And what we've also done with this PDX models is that we've done two things. Because we want to test immune the immune system. We've humanized these so that now what we do with a mouse is that we give the mouse a human immune system. We put in a human breast cancer biopsy from a patient, and the humanized mouse with a human white blood cells and platelets, etc., carries the patient's tumor. That's one way. Very expensive and difficult to do, difficult to replicate, but we got it down quite cheaply to about 150. You can buy these things for about 1,500 for one little mouse. We can get it down in our labs for 150, but that's still not enough. So the next thing we're doing is, in addition, is that we are also basically creating little organoids. So we can take in media the patient's tumor with the patient's immune system growing as little tiny little organs, breast cancer organs in culture media. And we can test out different variations of drugs based on that. Next slide. So the advantages of PDXs is that it basically replicates a patient tumor. It's transplantable, so you can try many, many different combinations. We have extensively characterized them. And the main characteristics are preserved. What do I mean by that? If a patient with, usually we take them out the primary tumor, metastasizes to the lung, then the mouse also has, when transplanted with the tumor also metastasizes to the lungs. The disadvantage is this immunotherapy, but we have now managed to basically find ways in which we can humanize the PDX models. Next slide. So again, my disclaimer, do not forget, this is a drug that we basically hold a patent to, but we have published this data a couple of years ago. We use these PDX models, and with this repurposed drug that targets nitric oxide, and in combination with chemotherapy, the red lines, what you see, the combination with chemotherapy, it significantly decreases tumor growth. Next slide. So we have now completed this phase 1/2 clinical study in triple-negative breast cancer. What we've done multiple biopsies in patients. In total, about 56 patients were recruited, 24 in the phase 2 portion. We've seen, next slide, good responses. This is a patient of mine. She's 36 years of age. She was pregnant when she was diagnosed with metaplastic breast cancer. We gave her lots of chemotherapy. Her tumor, she had a primary tumor in situ, and it grew on chemotherapy. And a few years after we completed the surgery and her treatment, her definitive treatment, she developed this huge lung metastases in the lung. We gave her this drug, this targeting iNOS, together with Abraxane, and you can see this remarkable decrease. We then resected it quickly because we didn't want any opportunity. We brought her up to the NCI. The NCI did this huge wedge resection of her tumor. Frankly, in July, and today is at the end of 2020, she remains free of treatment, on no drugs, and she still remains in remission. So that's very positive. So we've completed the study. The results look very promising in my mind. We're going to be presenting that shortly. Next slide. And what we see in the biopsies that we've taken is that this drug, next slide, changes the microenvironment. What you see here is very interesting. The E-kit herein is the cancer, and other than this purple, you don't see any other cells. So you have no other infiltrate. So the cancer, before treatment with this drug, does not permit white cells, lymphocytes from coming in, does not permit macrophages from coming in, does not permit anything from coming in. It is an immunosuppressive, immune cold tumor. No infiltrating lymphocytes can come in. Next slide. And when we treat it with this drug, what happens is, now you can see the green is PD-L1 on T cells. These T cells are coming in that express PD-L1. CD68 is a macrophage, and they can come in too. So what's happening now is, by treating this drug, it's not that we're killing necessarily the tumor, but we're allowing infiltrates to come in, immune infiltrates to come in, that can basically then enable killing of the tumor. Next slide. And here, this is the one of the study that we have done and completed, and I'm going to walk you through this a little bit. The first is the non-responders, and then these are the responders. Responders are in, the non-responders are in red, and you have this huge increase in non-responders macrophages. And we know in non-responders, if you have an increase in macrophages, that makes it totally not responsive to treatment. And that is, we know that from literature, we know that from our history. But if you respond, you don't have this increase into M2 macrophages. And these are lymphocytes, and if neutrophils, and if you have an infiltrate of neutrophils, basically you respond to treatment. And this is what we can see. This is a state-of-the-art type of imaging, where in the biopsy, we can actually see all the immune cells in your tumor, and we out 40 different markers, and we can figure out what is it that the drugs are doing to the immune system to enable cell killing. Next slide. So we've talked a little bit about metaplastic breast cancers, which has the worst prognosis of all TNBCs. It is refractory to standard chemotherapy. We know that most patients with metaplastic breast cancers not only are refractory to chemotherapy, but often relapse, and median survival is much shorter. We have two druggable targets. Both have been in clinical trials. These two pathways have been drugged in clinical trials and individually look good. Some simple. So if you have two drugs, they both look as if they can be used. We have a drug supply of both drugs. What will happen if we combine them? Will we have better effect? Next slide. So that's what we did. We used 1, 2, 3, 4, 5, 6, 7, 8, 9 different types of cell lines. The first two are cell lines, starting from BCM to PIM. Those are actually patient-derived xenografts. The first two were created when I was at Baylor, and the last 4 are created by collaborators Helen Pinnacle-Worms in MD Anderson. So by this close collaboration, we now have this huge, probably one of the largest supplies of renewable sources of metaplastic PDX that we can actually test drugs. Remember, I have 2 pathways. Next slide. Again, very talented postdoc, soon to be hopefully Dr. Reddy. And what she did was she basically looked in all our metaplastic breast cancer xenografts. And what you see in the green line, when we block both, you see this beautiful, first time ever I've ever seen this. By blocking it, you have a regression in tumor growth. Next slide. And again, and again. So this is in 4 different metaplastic breast cancer xenograft models. Next slide. And it kills. So by just targeting it, what this is called an apoptosis assay, a cell death assay. And on the bottom right-hand corner, you see lots and lots of brown spots, and that means that those are all dying cells. Next slide. So I'm going to summarize. I feel very compelled to find something to help. I've metaplastic breast cancer patients. It's a rare tumor, but I think if we understand what drives that, we can understand a lot of the reasons why cancers become resistant to therapy, and why they relapse. We have a first-in-class, LNMMA is this first-in-class, which I hold the patent to, and we have got robust responses in this clinical trial. We have correlative markers to show that we changed the immune environment to allow increased cell kill. Next slide. And we believe, I believe, in collaboration with my colleagues in MD Anderson, that we want to go ahead and begin a clinical trial in metaplastic breast cancer patients, targeting both pathways. And our preclinical data shows that this combination is effective. And the overarching hypothesis that in this rare subset of breast cancer, that there is an oncogenic relationship, a synergistic oncogenic relationship between these 2 major pathways, and if we simultaneously block these 2 pathways, this may be an effective targeted therapeutic approach for metaplastic breast cancer. Next slide. And that this basically affects the immune environment. It decreases these immunosuppressive macrophages. It increases T cells and allows increased killing. Next slide. And this is basically the summary of what I've just talked about. Next slide. and that's it. And I do have to, Sandy and everybody, I do have to put in my declarations. I do apologize, I might have forgotten. But basically, that's it. We've concentrated a lot on understanding what drives resistance and residual tumors. Why is it that pathways, these tumors do not respond to chemotherapy, standard therapies, and are they ways, in a pragmatic way, is there's drugs out there that we can use today in a clinical trial that can attack these residual tumors, these metaplastic stem-like tumors. Thank you.
Thank you so much, Dr. Chang. That was a great presentation full of information. I am sure that people walked away just like, okay, I've learned something new. So at this time, we're going to go ahead and take some questions. So anyone has a question, go ahead and add it to the chat box, or sorry, the comments, and we'll get those questions answered. I do have one already, and the question is, does insurance, including Medicare, cover treatments for metaplastic breast cancer?
Yeah, I mean, today's standard of care is chemotherapy, usually a taxane-based chemotherapy. And if your tumor happens to express PD-L1, then you will get an immune checkpoint. But that is the standard treatment to date that is available. So these treatments that we're talking about, that are more targeted, those will be done in a clinical trial. But today, insurance will pay for chemotherapy, and if PD-L1 positive, the tumor's PD-L1 positive immune checkpoints.
Okay. And I know that you mentioned about some clinical trials. That's something that you guys want to get into. Can you kind of give a little bit more information about that, or do you think there's going to be what's I'm looking for? What are going to be the requirements for being part of that clinical trial? Would you know already, or?
Probably, we just completed the study that I vaguely alluded to, but basically we're designing it. It's going to be a multi-center, hopefully national study, targeting these two pathways. And basically, we're going to focus on patients with metastatic breast cancer, triple negative, that we know basically that it's going to be a randomized study to standard therapy, which is chemo plus or minus immune checkpoints versus targeted therapies. So that study hopefully will start sometime. We're designing it, so probably start sometime in 2021.
Okay, thank you so much. Another question just came in, and it says, does the INOS inhibition plus taxane study have a name so we can be on the lookout for it when it is presented?
No, it's called that. It's called LMMA and taxane phase 1/2. I must think of, I'll think of, I'm right, it's written. I'm probably going to try and submit it to JCO, and it's being written up, probably be submitted early next year. But yeah, it does look good. It looks promising. With caveats, again, I can't overdo it because, I fell into this, we repurposed it, we patented it, and now I can't talk about it because, we're invented to it, and I'm really not trying to over. I really don't want to do it, but it is, for me, exciting. I think it's so hard because you get excited about things that you work on. You just happen to hold a pattern, and it sort of limits how much you can talk about it. But I think it's exciting, to be honest. And it
sounds exciting. Okay. The other question is, how is metaplastic diagnosed?
Histology. So we look at it, and instead of looking like the usual cobblestone epithelial tumors, it has these spindles. Sometimes it has a bits of bone and bits of squamous cell, which is like skin. It looks completely different by histology. It's very rare. It's less than 1% of all breast cancers. It's very rare, but it has the same stem qualities, as stem cells.
Okay, so if there's any additional questions, feel free to go ahead and add it to the comment section. In the meantime, I'm just going to go ahead and say thank you again, Dr. Chang. Great presentation, great information on cancer stem cells and breast cancer. Just making sure no other comments are coming through. And it was great. Thank you again. And also just thank you to the Alamo Breast Cancer Foundation for partnering up. We're going to be doing this again next year. A question just came in, so let me read that for you. I hope that I have the right. I hope I have this right. Okay. I hope I have this right. With the experimental treatment, you were combining taxane and the INOS inhibition. Why that combination? And do they work together?
Yes, they were together, and we completed the clinical trial. We're going to be submitting the manuscript. So data lock is done already. So we have the responses. We know that that study is complete. Then we'll be designing the next study.
Okay. All right. Um, any other questions? Feel free to add it. We'll be wrapping up in the next 5 minutes. Oh, more questions are coming in.
Okay,
okay.
I'm happy. And I'm happy to
So
email me anytime if you run out of time, okay? So email me and I'll respond. No problem.
All right, so we're just going to ask this last question and then we'll wrap things up. And the question is, show besides the drugs that are in the phase 1 and 2 with you, are there other drugs that are out there to target this?
You know, I haven't done a search recently, but I don't think that there are many metaplastic specific. There are not many clinical trials specific for metaplastic breast cancers. So this would be one of the few. If I don't quote me, that was when I last searched on clinicaltrials.gov. I don't think there are any other clinical trials on metaplastic breast cancer.
Okay. All right. Another question. How do pathologists learn how to recognize these?
They look very different. So it's in the training they will see it.
Okay. Okay. All right. So with that, I'm going to go ahead and say thank you to Alamo, thank you to our attendees, thank you to Dr. Chang, and just a few reminders to go ahead and check out the Alamo Foundation's Facebook page. They have the Hot Topic mentor sessions, and Dr. Chang will be there tonight. So keep in mind, keep watching that for the rest of the week, and that the annual meeting for AACR 2021 the dates have been announced. So that's going to be April 10th through the 15th, 2021, and May 17th to the 21st. Advocate members can register for $99, and if you are a member of AACR, you are going to be able to get there with no fee. And also just check out the AACR website. We have great information on advocacy and some of the programs that we're doing at AACR. So with that said, unless we have any other questions, which I don't think, just double checking. No. Dr. Chang, thank you,
Thank you, Karen.
thank you so much
Thank
for all
you.
of this.
Bye, guys. Take care. See you this evening.
Bye-bye.
Bye.
Yep.
word a glass of wine can prevent cancer, or does it cause cancer?
I don't think this video is about scolding those people that love and care and those people that have misstepped with their words.
Have you tried yoga? Yeah, I have.
I think this is really about the NBC community having a good laugh.
Have you swam in Lake Tiki Taka? Tiki Taka?